Dr. Foyouzi is a board-certified REI with a subspecialty in medical genetics from the American Board of Obstetrics and Gynecology and the American Board of Medical Genetics and Genomics. She thrives on solving the complex genetics inherent to reproductive failure and considers the results of her efforts, healthy children, the greatest results of her work. Dr. Foyouzi is a reviewer of manuscripts and abstracts for multiple organizations and is a member of ACMG position statement on preimplantation genetic testing for polygenic risk scoring. Dr. Foyouzi will discuss genetics and PGT. Thank you.
Hi, my name is Nastaran Foyouzi. I am a reproductive endocrinology and medical geneticist currently working at Tree of Life in LA. I wanted to thank Gene Conference for inviting me to discuss about the challenges of PGT, and my talk today is about the clinical utility of PGT-P. This is a paper that was recently published through the American College of Medical Geneticists through the task force that was consisted by statistician, epigeneticist, geneticists, OBGYN geneticists, and REI geneticists, molecular geneticists, that we all put all the data together and put the basically statement with regards to clinical utility of PGT-P. Okay. So let's start from talking about the polygenic risk score. Polygenic risk score is a basically risk stratification that identifies the people that they are at a higher risk for some of the heterogeneous disease to provide them with a early intervention. It's based on the association of the multiple SNPs that will be derived from the JWAS study. However, it has some challenges by itself. One is that each SNP typically has a very relatively small contribution to the person's genetic risks. Second is oftenly mapped to the non-coding region of the DNA, that they don't have any function or no obvious function. And also they are correlated with the many other SNPs. Therefore, it makes each SNP alone to have a very limited significance. And also we should understand that they are moderately associated with the disease in question. So it's not like a PGTM or like a monogenic disease that they follow the Mendelian inheritance, have a much higher association with the disease at risk. Currently, up to recently, basically, it was available only in the limited scope in adult clinical care. Even currently it's not available in pediatric or prenatal care, and we are now jumping suddenly to the embryo selection through the using the PRS. One of the most predictive clinical PRS that will be used is for coronary artery disease. We have to understand, even when we are using PRS in coronary artery disease that has much more data on it, the risk will vary during the life cycle of the person, because the age has some effect, the duration of the environment, the exposure also has some effect. If you could look at these two graph, the first one will show the effect of the age on the cumulative incidence of the disease, and the second, it will shows the polygenic risk score with regards to the lifetime risk of the disease. So as much as the age will increase, of course, the polygenic risk score will be changed. And also the life habit of the person could change the PRS. And that's the reason even when the adult with coronary artery disease, when come to the cardiologist, it's not going to be a lifetime one PRS score for them. It will change by intervention, the score that they stratify them according to the PRS. Also, another things to consider is the penetrance of the disease in the PRS. Majority of this disease, they are heterogeneous. They don't have a 100% penetrance, means that, for example, in coronary artery disease, if we have in the very higher top decile of the polygenic risk score, 50% of them, they never develop the CAD, or even if they are in the very lower decile of the bottom decile of the PRS, 16% of them, they can develop the coronary artery disease. And this makes it, even in adult medicine, PRS to be has a moderate or limited significance in predicting the disease. Now we can see how it's going to be in the embryo, how we are going to do this with the embryo who doesn't have any exposure to the environment. The first study basically was published by Nathan Traff, that he introduced the PGT-P to specifically screen for the embryo for one or more polygenic disorder. And his purpose of this testing was to identify the embryos that they have increased lifetime risk of developing any specific heterogeneous disease like type 1 diabetes and coronary artery disease. When I was talking with the Nathan Traff, his focus is mostly on type 1 diabetes, which of course it's more acceptable rather than the other traits like a height, like IQ, that has some ethical effect. There are some of the companies that they are also offering other than genomic prediction, which some like Myome, that they are it's claimed that they wanted to offer to educational attainment and also to the selecting for the IQ, that they are really putting this PGT-P under the Zoom and under the ethical questions associated with the PGT-P. No, currently the main company is a genomic prediction, because they are also accepting the embryo DNA, and they not only offer PGT-P, offer other kind of the pre-implantation genetic testing. So for the PGT-P, their panel includes type 1 diabetes, breast cancer, type 2 diabetes, basal cell carcinoma, schizophrenia, malignant melanoma, hypercholesterolemia, hypertension, CAD, heart attack, prostate cancer, and testicular cancer. First of all, there is no overlap between the disease. If somebody, for example, has a history of bipolar disorder, you cannot use the PGT-P because it's not in the panel, and you cannot basically overlap the data from, for example, schizophrenia to predict the bipolar disorder. Nathan Traff, basically in his paper, when he introduced the PGT-P, he mentioned that we can interpret the results. He said that if the score of the embryo goes above the top 2% risk of the population matched individual considered as a high risk, if it's at the 2% or less, then it considered as a normal risk. He mentioned that his inconclusive risk is less than 1%, means that there is the data is not interpretable, and there is a less than 5% chance of no amplification, which he recommends to rebiopsy. But then the question comes that if for the PGT-P alone, the rebiopsy will put the embryo in the higher risk of loss, or accepting the risk of loss, or downgrading of the embryo. Now, this is our paper that we recently published, and in February 2023 was published in Genetics of Medicine. So we talked in our paper about the multiple consideration. One is a gene and environmental interaction. It is one of the major considerations that impact the environmental effect on the PRS. As we know, PRS is generated from the JWAS study, that they usually identify the loci that has interaction with the environmental factors. And it has a significant association between the environmental factor and the disease of the disease trait because of the gene environmental interaction. Also, most of the common disease are adult onset. So the exposure typically happened during the over several decades. And when we are doing the calculation for clinical utility of PGT-P, we are making the assumption that the environment that we are doing to the assumption, are doing this risk assessment today is the same as the environment for the embryo when the embryo will grow up several decades later, which I think that it's a little premature assumption. Also, we have to understand that the predictive power of PRS is maximized when the person from the same environment as the JWAS study will be compared with the embryo. And this is really, really difficult when specifically we are using the embryos that they are from the same, they have the same biological parents, and they are going to compare it with their siblings, not with the JWAS population. Now, another things that we need to look is the expected gain. What is the expected gain? Is the expected difference in the trait when we choosing the embryo with the higher polygenic score compared to the embryo that randomly were selected. So if you look at this graph, you could see that on the y-axis, there is an expected difference in education. That's one of the traits that hypothetically we wanted to, for example, look with the PGT-P. And then on the x-axis, you will see the red one are the European ancestry, and it will compare between the family. And the blue one are the different ancestry, but within the family. So of course, between the family means that they are from two different families. Within the family means that they are comparing inside each family. Now, the 1.36-year difference in education attainment, if we select the embryo with the through the PGT-P, from if we compare this embryo randomly from the same population that JWAS study has been done, it will increase the difference in the basically education in 1.36 years. Now, if we choose to, I'm sorry, if we choose from the same JWAS study, it will increase 1.55 years of the difference in the educational attainment. If we choose from a completely different JWAS study as a control, then this educational attainment goes to 1.36. And you see that this makes the change. It's not so much, but the different environment, when we compare, we wanted to show that has an effect on basically risk score. Now, this difference is much, much higher when we are comparing within the family, as well as different ancestry, as you could see, because the database is the mostly European database and UK biobank, then the predictive value is much better compared when you are going to the different ancestries that it's not compatible with the European ancestry. Next things is, as we talked about the sharing the biological parent effect, if we have the two biological parents, of course, the expected gain, as I showed in the previous slide, it's going to be smaller for two reasons. One, every embryo genome is a mixture of the biological parents. So there is less variation in the embryos compared to when you have the different embryo from different families. And this less variation become more pronounced if you have a assertive mating or you have the consanguinity in the family. So it's almost impossible you could find a very, very high score and very, very low score in PRS in the embryo from the same family. Majority of them will cluster closer to each other, and that also makes them PRS or PGT-P, the predictive value of the PRS or PGT-P less. And decrease the predictive power of the PRS. The next thing is the sizable portion of the predictive power of the polygenic score is based on the gene and environmental correlation. There are two things to consider here. One, the embryos are coming from the different environments. They are grown 5 days in the culture medium. There is some epigenetic effect. We don't know what are the epigenetic effects, or growing the embryo in the culture for 5 days or 7 days has any effect on the PRS. And the second is, again, make the assumption that the same environmental factor, it's going to be applied to this embryo in next couple decades when the age is, when we are really wanted to see the lifetime risk of the PRS. One thing is that I needed to bring it up is that there are some claim that they say that if you make more siblings or more embryo, then you have a much greater relative risk and much higher predictive power of the PRS. This is not true. Up to the 5 embryo, because they are from the same biological parents, up to the 5 embryo, yes, the expected gain will be increased. But after 5, the expected gain will not going to be increased dramatically, and more than as much as we go more, that this dramatically expected gain will be decreased. Next thing is the unpredictable variation. It's very, very important to communicate this with the parents, with the customer who they really wanted to go for the PGT-P. The PRS PGT-P is only probabilistic. It doesn't capture the role of the de novo genetic events. It doesn't capture the role of the monogenetic variants or environmental risk factors. So it's very, very important in these people that they wanted to go for PGT-P to have the genetic carrier screening before going for that, because we don't know if there is any monogenetic disorder, does it affect the PRS or not? So that's important. The next thing is the overconfidence in the utility of the PGT-P by neglecting the variants and inability to capture all of the genetic source of all of the genetic variation that exists. We don't know what are all the genetic, our science hasn't reached to the point to know what are all of the basically genetic pathways. So we don't know that, and we should understand for heterogeneous disease, of course, this variance is much bigger. For example, is this, that when we look at the biological parents that they're from European ancestry, when we look at the gain of the education with 95% prediction interval, this could range from plus 4.2 to minus 3.2. This is a huge variation. Next thing is to understand the difference between absolute risk factor, and relative risk factor. This is very, very important when you're interpreting the results of the PGT-P. So absolute risk reduction or risk difference, basically it gives the actual difference in risk between the one group compared to the another group, and the comparison is between the people that they receive the intervention. However, the relative risk reduction is a proportion, is a percentage reduction when we're comparing the one group with the control group, and relative risk reduction can be misleading. Let's look at this embryo that showed in the PGT-P has the twice ratio of increase the risk of the breast cancer. The risk was 24%. However, in the population, it was about 12%. And these are our European, again, I'm thinking that the embryo is the white, is European ancestry. It was 12%. When I calculate, when we get basically the relative risk, it comes to twice. So you are not decreasing twice the risk of the breast cancer in this when we are avoiding to transfer this embryo, because the risk is 12% in population. So you are only decreasing 12%. Your absolute risk reduction is only 12%. And this means that to understand the difference between the risk percentile, this embryo was in 99% of the risk percentile when compared with the other embryos from the same biological parents. But when we are looking at the general population, the risk reduction is 12%, is not 99%, or it's not even basically 50% or half. Then the clinical outcome. So the risk of the clinical outcome when with this kind of disease that they are heterogeneous and they are rare disease is very low. And that makes it that when we are doing the risk stratification, small reduction in absolute risk can correspond to the larger reduction in relative risk and increase in the, it can correspond to the larger reduction, yes, in relative risk, and that misleading. This exaggerate the relative risk, which it's not as much as it should be, as we discussed. Also, when we increase the risk of very rare disease, carries a much smaller overall risk of the disease than for the more common disease that have a much higher prevalence in the population. For example, consider type 1 diabetes, a relative risk reduction of 35% for the parents that they have a European ancestry. If we consider that the lifetime risk of the type 1 diabetes in US is only 0.34%, could imply the risk reduction of only 0.12 percentage point. So this is important. So when you are selecting the embryo, you are only reducing 0.12% of the risk. You are not reducing more than that, or 35%. So this is very important to understand, and makes it important to understand what is the percentile risk, what is the relative risk, and what is the absolute risk. A person with a very, very high risk percentile, 85%, may have a very low absolute risk. As I showed in the breast cancer, it has 99% risk percentile, but it's only interpreted to absolute risk reduction of only 12%. So this is very important to understand when you are communicating with your patients. Unintended consequences. As we know, there is an additional risk of the polytherapy. Polytherapy, which means that the tendency of genetic variant to affect the multiple phenotype. As you know, these are heterogeneous disease. They are interacting with multiple network of the genes. So is that possible that if we are selecting against the one trait, we are increasing the possibility of phenotype of another trait? So example of this is that when we are selecting for the high educational attainment, risk of bipolar disorder in these embryos will increase by 16% from the absolute risk of the 1%. And this needs to be communicated with the patient. Is that really acceptable by the patient? Yes, it's not so much. This risk is low. Majority of the bad traits, when we are selecting against them, they basically go towards they travel together toward, but there are some of them that it couldn't be, and it could increase the risk of the basically another trait. For example, as you know, ADHD people, they are very smart. They have a majority of them, they have a very good educational attainment. If we do that selection, or we get more ADHD kids, or selecting more embryos with a higher risk of the ADHD in future. Now, at the end, we mentioned in our paper that points to consider is, first of all, always understand that PGT-P is a screening tool. And the deficiency of the screening of this screening tool is it doesn't have a diagnostic tool. When we are presenting a clinical screening tool, according to the American College ACMG, we have to have the diagnostic test, and we don't have it there. And that means that it's still early to make it as a really clinical test. Second, reference genome database is the Western European. Therefore, it will limit and decrease the predictive value of the PRS lower for the other population other than the European ancestry. have to consider the clinical utility of the PRS that impacted by multiple factors: environmental interaction, phenotype variability of the disease, expression of the disease is different. In some people, expression of the disease could be very minimal. In some people, could be very severe. Genetic admixture, network of the genomes that they are working with each other in this kind of heterogeneous disease, and also presence of the single gene variants in the situation that the both couple are the carrier of the same genetic abnormality or the X-linked dominant disease, or they have any effect on the utility of the PRS, we don't know. Also, understand that the PRS data are generated all from the retrospective data. Of course, there is an uncertainty about the clinical relevance of this score that apply to the embryo today, that they may experience significantly different environment in future rather than today, and this will probably change the risk score in these embryos later in life. And then it comes to the question, did we do the right things? If you choose the embryo that has a lower risk, and then in future, because of the change of the environment, the risk went up when we reanalyze the risk score, then what is the utility of doing this PGT-P at this point? Also, we need, basically brought it up that we really need additional research into the effect of both positive and negative polytropy with regards to when we are selecting against this kind of heterogeneous trait and make the decision making. It's a little more difficult at this point. Another thing is less variance and having this shared the same parents, that it makes the predictive power of the PRS when we are selecting the embryo lower. And then, of course, if of course, we don't know what is the environment in future and what is the effect of the embryo that is grown in the culture medium with the IVF and in future. We are comparing these embryos with the control that they are from JVOS study, adult people that they are conceived spontaneously. Is that make the difference? We know that the IVF pregnancies are associated with some complication of the pregnancy. Is the IVF going to affect the risk score for some of this PRS and polygenic disease in future as well? We don't know. So the more research is needed. The clinical validity of the test is uncertain. Again, I'm bringing the effect of epigenetic effect in several stages of embryo development. And if the cumulative effect of this environmental factor in the embryo could negatively affect the clinical validity of the PGT-P, the next point that should consider that these are mostly JVOS-derived PRS from the adult onset disease, and they have the correlation, they put in the PRS in adult disease with consideration of the biometric and biochemical marker, which we don't have it at this point for the embryo. And that also makes the predictive value of PGT-P limited. And also understanding that there are some changes in the environment that we don't know that may change the PRS, that according to that, we are selecting the embryo today, but could be some score in future when the embryo grows. Also, as we talked, that the different environment could also assumption of the same environment of today to the future is also problematic. So in conclusion, I wanted to bring everybody's attention and urge everyone to about the responsible communication of the results of the PGT-P when you are counseling your patients. I would recommend to use the third-party genetic counselor, not only the genomic prediction or the companies, because of the conflict of interest in that. Also, also communicate very, very clearly about all of the points that I discussed with the parents with regards to how they are choosing the embryo. Also, I would urge that FTC or Federal Trade Commission to oversee the information disclosure given the social risks, especially for the trait like educational attainment, for the height, for example, IQ, and this stuff. Really, really, we need some oversee with regards to the ethical or regulatory framework of that. Also, we need the ASRM and societies, as well as the FTC put some guideline, and also like 1990 to 2000 when the FTC came in, and they basically made all the IVF clinic to report their data to SART because it was due to misleading rate of the successful pregnancy. We need this kind of oversee when the new genetic testing come into the market, especially when they are offering direct to consumer. So we need more oversee and basically better consenting of the patients and communicating better the pros and cons of and deficiencies, and also the weakness and strength of the study, not only the weakness. At the end, I don't want you think about that I'm completely against the PGT-P. No, I think that it's actually, it is a starting point, but it needs more research. I don't think it's a clinical test at this point. It needs more study to be done, not the population study, not the 10 years, 15 years, but I think we need a little more, or at least we have to communicate this with the patients rather than just advocating and advertising it, to discuss about all of the steps. When I was talking with Nathan Treff, he has actually very good panel that it's not really towards the non-medical traits. And I approve that. And he's mostly focused on type 1 diabetes. And he thinks that with this PGT-P, it will decrease 40 to 70% risk of the type 1 diabetes. But remember, this is the relative risk that he's talking, not really the absolute risk. Absolute risk is something around 12 to 15 or 17% because of you should see the incidence of the type 1 diabetes in general population. This brings my point that when you are talking with your patients, please get a very thorough family history. It will help. Not only in PGT-M, also in PGT-P. If somebody has a multiple family member with a heterogeneous disease, most likely they could have some of the hereditary pattern of inheritance. Then at that point, of course, it makes it very expensive to go this route. But one of the things to consider is to go for the people that they show the phenotype, test them genetically for the trait that they show. And if there is a known gene, we can do the PGT-M with much better predictive value. But if not, and it's still heterogeneous, you can, yes, offer PGT-P. However, you have to really, really talk with them and give them the information about what is exactly the pros and cons and what they are doing, how they are selecting the embryo, and what they are going to get in future that it's not at all guaranteed. Thanks everybody for listening to my presentation. Again, I really apologize for not being able to be in person and also not being able to be in the post-presentation panel. But if there was any question, more than happy to answer. You can use my Tree of Life fertility email address as a drfoyouzi@tlcfertility.com. Thank you so much and have a great day.